I think we've been swept off with AHI, but I think we need to look at sleep apnea in a big circle, and that's just one very small circle. The other problem I found in my interest with this is sleep studies are cross-sectional, and they are subject to inter and intra-study variability. And I'll touch on a case at the end for you to give you a bit of an understanding. So just because you have a sleep study and it might be a home-based sleep study, and I had a patient that was sent off to an ear, nose and throat doctor, and she was smashing her teeth around, she was snoring a little bit, and she was a bit guarded, played her cards pretty close to her chest. And I said, well, why don't we go off and get the ear, nose and throat doctor to check you out? Anyway, he said, no, I wouldn't want a sleep study. Sent her off for a lab-based sleep study, and she got an AHI of 28. He said, well, that's crap. We can't have that. She's got a Epworth score of 6, and I'll come to Epworth score 2 shortly. So that can't be right. Let's have another sleep study. We'll put you in a hospital. That can't be right. She came back with a AHI double that, 56, within 4 weeks apart. So just because you have a sleep study and you come under the radar, it doesn't mean you're going to come under the radar in a month's time. So it really does question how we think about sleep studies. They are cross-sectional at a point in time, and it may not reflect our circumstances in continuity. Key thing I just want you to get out of here, a lot of this stuff you can get on Google, right, Dr. Nolder? I hate Google. Just understand that normal is less than 5 for AHI, severe is plus 30, or if you want to add RDI, 40, and that's what we call the widow maker, because you don't wake up, die in your sleep, all right? Children, normal AHI is 0. It's not normal to have any of it. So again, this is where parameters and assessment for kids are different to adults. And another interesting thing is we just don't look at the indice, the RDI, the AHI, but you also look for what we call as the nadir-O2. And this is the lowest level that these patients drop with their oxygen saturations, arterial oxygen saturations in their sleep. And nadir-O2 to me is probably the more important thing. It's more important than AHI. So I look at that. And anything under 80 is bad. In a kid, under 96 is bad. Again, very different parameters.
But I also would look at time spent below.
Good point.
80,
yes, good point.
Because it might be that you go down to 80 just once,
yep.
Or it might be that across a night you spend quite a lot of your night as a proportion of the total sleep time
yep.
at that low, at a very low level.
Good point. Yep.
And cognitively, that seems to
yep.
be an important factor.
Yeah, that's a good point. And some of the sleep studies, they obviously report on that too.
Increasingly so.
Yeah.
Time spent below 90,
you got it.
Time spent below 80, and so on.
You're good. So
you measure that when they're coming to the night?
What's that, mate?
The oxygen saturation.
Okay, you can do, but you know what? I'm a dentist, I'm not a doctor. And I think this is something where you've got to be very, very careful. Because these guys, this is how they make their bucks. And we're wanting to develop an interactive process here. We have our game, we have our turf. Let's focus and do that job well and leave the medical assessment to the medicos. But at the end of the day, it's a team effort. You know, it's not where one person can solve this riddle on their own. And really, we are in the front line. As GPs, we are the front line. We are the gatekeepers, and we are most exposed to this condition. We are best placed to diagnose, or potentially diagnose, or at least see some red flags and forward that for further assessment. And that's why dentists really need to have this drilled into them. Big time. All right?
But I think to answer your question, unless you've got something like COPD, your O2 sats during the daytime will be normal. It's only at night that they're dropping.
Yeah, they drop. Good point. That's a good point. Yeah, that's a good point. So, you know, then the question comes, well, okay, why do some people get this and some people don't? This is interesting. So, we look at the pathophysiological things here, and it starts again with the nose, and we look for anatomical structures. We might look for a narrow nose. You might look for one nostril different shape to the other, which is indicative of a deviated nasal septum. We might look for, sometimes you can see that on an OPG, but remember it's 2 dimensions of 3, don't get sold on an OPG. Adenotonsillar hypertrophy. You know, that gets big because the tonsils are becoming the samplers because of mouth breathing. So we only get that problem because of mouth breathing. Craniofacial abnormalities. Obviously, if we've got a small lower jaw, or worse, in my experience, a small top jaw. I'm bigger on detecting midface deficiency, particularly in children, treat midface deficiency a lot earlier than what we do with mandibular deficiency. Things like neuromuscular disease, neoplasia, things occupying space. All of these things are what we start to look for in patients that are at risk of sleep disordered breathing. Allergies developing in kids. Now, you know, Professor McIntosh talked at length about this, the role of breastfeeding and the role that plays in helping to develop tongue posture and correct tongue posture and feeding patterns. You know, it's the lips together, it's the tongue against the palate, and we breathe through our nose. A lot of that comes from breastfeeding. But if we don't breastfeed, why? Because mum can't afford to. She's going to throw you in a daycare, she's got to get back on the tools. Oh, well, now I'm not getting breastfed so much. Apparently the immunisation thing isn't so much. Apparently it's more about the tongue posture. But then, you know, you get dropped off at a daycare, and this is what the ear, nose and throat doctors love. They call that the human petri dish. So now I'm going to put my kid in a daycare full of bugs. And this is a kid that may have already initial signs of an underdeveloped maxilla because of an inadequate period of breastfeeding. And then we don't get good clearance of the upper airway, and then we start to develop allergies, and then it makes it worse. And then, once mum picks you up from daycare, and you remember what she looks like, now she's going to take you to the heated swimming pool because she doesn't want you to drown. And the problem with a heated swimming pool is chlorine. Again, it's something else we're not meant to have. So I asked Professor McIntosh, and I say, Professor McIntosh, you know, if you've got a kid and you want them to learn to swim, where are you going to take them to swim? And he said, mate, I'm going to throw them in the ocean. I'm going to throw them in the ocean because of ozone. There's no way my kids are going to learn to swim in a heated swimming pool. And I've done that experience with my kids. First kid, paranoid about drowning in a pool, heated swimming pool, adenoids and tonsils out by 4. Twin boys, threw them in the ocean, not a problem. I took the credit from it because I think boys follow their father and girls follow their mother, but my wife is not eating that. But just understand the dynamics here. There's a lot of things that are happening in our society because that's the way we're thrown into this world, and we consider that normal. But it's not. And this then down the track is leading to sleep disordered breathing, and that then is leading to bruxism, and then they're ending up on your doorstep needing a root canal. It starts a day they're born. Forget about the diet and the oral hygiene, and definitely forget about the bottled water. I reckon that's crap. Obesity, neck circumference, a couple of classic figures there, and also a BMI greater than 28. A lot of the anaesthetists use these figures. They have what's called a stop-bang, and stop-bang is a very quick, clear classification system they use in triaging patients at risk of complication during anaesthesia. Sleeping on your back, we understand that puts us at greater risk. Bottle feeding when young, again it comes down to posture, tongue posturing and so on, and tongue engrams, what we call muscle engrams. Environmental factors, I talked about the airlines, you know, drugs. Okay, that might dry the mouth, it might dry the airway, but it also puts the body under a lot of load. And when the body's going 1,000 miles an hour because you had to hit its speed, what does it need? It needs more oxygen. So the body is no different than a car. If I've got a bit of a block carby and I drive that car slowly, it won't stall, it will run quite well. If I put my foot down, it will stall. And the body is no different.